Welcome to Healing with Her, the podcast where women in medicine share bold and honest conversations from the front lines of healthcare. Step into the world of Black women medical professionals as they unpack the power of healing, the weight of care, and the beauty of showing up whole.
Welcome to Healing with Her, the podcast where women in medicine share bold, honest, and healing conversations from the front lines of healthcare. This podcast was born from an overarching goal to find connection in medicine and address important topics in our community. The information shared on Healing with Her is intended for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your physician or other qualified healthcare provider with any questions you may have regarding your health. The views expressed by the hosts and guests are their own and do not necessarily reflect those of their institutions or employers. So with that, March represents Colon Cancer Awareness Month. And today we're talking about colon cancer, what it is, how to prevent it, and why early detection matters. I'm your host, Dr. Kimberly Wooten. I'm a head and neck surgeon, and this is Dr. Emmy Nylander, who is an OBGYN. And we are here to welcome my esteemed colleague, Dr. Timothy Adams, who is a fellowship-trained colorectal surgeon in Buffalo, New York. Thank you so much for joining us today.
Thank you for having me.
So I first want to start with talking about the general information about colon cancer. And I know recently it's been in the news with the past couple of years. One of my favorites, Chadwick Boseman, passed away with colon cancer. And then more recently, a very popular teen star, James Van Der Beek, also passed away. And so I really want us to talk about how important it is for our community and why we really should care about it. So I first want to start with, what is colon cancer and why is it something that our community should be more educated about?
So colon cancer, as the name would describe, is cancer involving the colon. It affects millions of people in the United States. It's the third leading cancer in the United States, lung cancer being number one, prostate for men being number two, breast cancer for women being number two, and colon cancer following a close third behind those. Mm-hmm. Everyone has a colon, so therefore everyone can be potentially at risk for getting colon cancer. When I started my training, colon cancer was sort of viewed as a cancer of the older people, the elderly. At that time, we were doing screening starting at 50 years of age, and that seemed to be appropriate. But ever since COVID, I would say we started to see a dramatic increase, about 2% increases in per year of colon cancer in the younger population, that population that's less than 50 years of age. I started in my own practice seeing patients who were in their 20s with colon cancer, and some of them with metastatic colon cancer. Some of them did not survive it, and here they never even made it to the age of 30. So this started to become more of a larger problem than we first thought it was. We thought these cases were sporadic, but then we started realizing that it's not just happening in Buffalo. It's not just happening in certain parts of the country. It's happening across the board. And so the governance committee, who sort of is responsible for determining who gets screened and at the age that you start getting screened, made a change in what they would consider should be your first colonoscopy. And that age dropped from 50 to 45. Currently, there's still ongoing studies to see if that might drop again to maybe 40 from 45. Colon cancer affects the African American community at a very high rate as well. Oftentimes when we do get diagnosed, it's also at a later stage, and we have a higher rate or a lower rate of survival when we do get diagnosed with colon cancer. There are a multitude of reasons for that, which we'll get into, but it is very important that even if you feel great, so colon cancer is one of those types of cancers that it doesn't matter if you feel good, you can still have cancer. And that's where screenings come into play. You've heard me mention colonoscopies and their importance. And so even if you're out there and you're feeling great, you don't have any issues, any kind of symptoms, and we'll talk about that too, you should still get your screening at the appropriate time.
Well, that's a lot of information, and thank you for that. So what would you say would be the biggest, I guess, symptoms of colon cancer and things that people should pay attention to, especially if they haven't had a colonoscopy?
So I think that a lot of times the reasons why people won't get a colonoscopy is mainly out of fear. I would say in the African American community, there's a distrust. We don't have a good history with the healthcare system as far as what they will tell us and what we can believe that they're saying to us. So many of us are out there just trying to figure it out on our own. And, who do we talk to? Our friends who are often not physicians, and you kind of agree with each other that, you don't really need these things done and you'll be fine. But certainly some of the symptoms that you definitely want to pay attention to is if you've had changes in your bowel habits. Maybe you used to move your bowels once a day and now you're moving them once every other day. Mm-hmm. Changes in shape. They used to be large bowel movements, but now they're small, maybe pencil shape. Your stool may have gone from being brown to black like this microphone before me. You may notice blood in the stool, blood on the toilet paper with wiping. Changes in appetite, a feeling of fullness, more difficulties with moving your bowels. Any of these subtle changes you can sometimes just chalk up to, you just ate something that disagreed with you, or maybe your hemorrhoids are acting up. But if you've never had a colonoscopy or you've never been seen by a physician, these are situations and these are symptoms you really want to follow up with your doctor about. Let them make the decision on if this is something that requires something more, a more serious investigation, or just simply some creams to be applied to your hemorrhoids. But don't make those decisions on your own.
Yeah, I think, especially my family, I know when they talked about it, and I haven't quite met the age for a colonoscopy just yet,
Right.
But I am worried about the go lightly or the PrEP. So can you tell us a little bit about what that is, and is it something that we need to be worried about or concerned about? Because I've certainly heard from people that that's something that they really don't like.
Right. So I've never met a patient who liked the PrEP. That's for sure. Yeah. So I won't sit here and act as though it's a delicious thing to do. It's not. I've had 2 colonoscopies myself, and I didn't enjoy the PrEP, but it's nothing to be fearful of. Yes, sometimes patients may get nauseated, sometimes they may throw up, but for the most part, people are able to tolerate it and get through it. There's more than one PrEP. None of them taste good, but some of them may agree with you a little bit better than the others. Mm-hmm. So I always tell patients, if you had a colonoscopy, number one, and you didn't like the PrEP, then make note of what PrEP you had. So the next time the colonoscopy comes up, you can share with your doctor, well, last time I had that, I really didn't like it. They can always change it to something different. The manufacturer will tell you that their PrEP is the best, but quite honestly, the best PrEP is the one the patient takes, right? So it doesn't matter what the statistics show about or what a journal article may say. If you don't like it, you're not going to take it, and your PrEP's not going to be adequate. So you just simply share or remember what one you had and then share with your doc. For those who have not had one, well, it's just going to be an experience for you, and you'll take from that experience knowledge to help you with the next colonoscopy that you have. But people get through it. You'll get through it. It's not horrible. I think besides the PrEP, there's a couple of things. One, you also can't eat solid food on the night before the colonoscopy, because you don't want to be putting things into the colon when you're trying to get things out of the colon. So you can drink as much liquids as you want. Sometimes I'll hear people say or think that they can only have water. You can have water, but you can also have Jell-O and juice and beef broth and chicken broth, coffee, tea, anything that's clear, you can have it. Or I should say anything that's see-through, you can have it. You don't have to only have water. But no, you can't have Big Mac, hot dogs, and eggs for breakfast and think that it's okay. You do have to stick to a liquid diet, but you get through it. And for this colonoscopy itself, you're sedated, so you're not up, you're not feeling it. The hard part is the night before. The easy part is the colonoscopy.
Okay. Yeah. And is a colonoscopy the only way to actually screen or test for colon cancer?
No, it's the best way. So right now you've seen commercials for Cologuard. I don't have an issue with Cologuard. I'm a fan of Cologuard, but I think it has a role. If a patient comes into my office and they're adamant that they're not getting a colonoscopy, then I'll say, well, at least let me do Cologuard. Patients will say, well, since I don't feel bad, I don't feel the need to get the colonoscopy.
Okay.
Well, if the Cologuard is positive, then that same patient who was adamant about not getting the colonoscopy now is willing to get the colonoscopy because they have this test that says that, you have something that's in you. But the Cologuard test isn't a substitute for a colonoscopy. Again, to me, it's something that is designated for certain patient populations that don't want to get colonoscopies. But it can be utilized as a screening tool. The accuracy is not as good as a colonoscopy. It does identify 92% of people with colon cancer, but it only identifies 40% of patients with polyps. So colonoscopy, it's a very subtle difference, but colonoscopies are not just there to identify colon cancer. It's there to prevent it.
Yeah.
And the only way you prevent it is by identifying polyps so you can remove them before they turn to colon cancer.
Right.
So Cologuard, well, yes, if you've got colon cancer, Cologuard will be very good at identifying that. But if you don't, and you simply have polyps that could easily be removed, well, 60% of you are going to walk away thinking you're okay, and you're not. So that's another reason why I would stick with a colonoscopy. But you have Cologuard, which is the newest test. And then you have other stool tests that are out there that's looking at blood in the stool. And if that's positive, you'd get a colonoscopy. Cologuard looks at your DNA within the stool. So it's looking for different factors that are DNA related that could mean that you have a polyp or a mass or a colon cancer. But the other stool tests just test for blood. And so those tests, again, I default those tests to patients who are unwilling to get a colonoscopy.
That's the Hemocult test.
That's the
right?
Hemocult
Yeah,
test,
that's what we
correct.
used to do. OBGYNs used to do them. We don't do them anymore. But
Yeah, we don't do them as much anymore. You used to couple it with a flexible sigmoidoscopy, which is just a fancy way of saying a short colonoscopy. But the problem with that test, even when it was coupled with the short colonoscopy, is you're missing tumors on the right side. So the colon's about 5 feet long. It starts on your right side, makes this sort of upside down U in your belly. Starts on the right, ends at the anus, which we'll say is on the left side of the body. So when you do a colonoscopy, you start at the anus and you work your way back to the right side. We used to think that if you didn't have any polyps on the left side of your colon, then you didn't have any polyps on the right side. That's not true. You could have, there's 15 to 25% of patients who may have polyps on the right side, although they have no polyps on the left. And so once again, we're a missing patient. So we got rid of Hemocult plus flexible sigmoidoscopy and substituted, say everyone should get a colonoscopy, right? So again, there are certain patient populations where you may default to the Hemocult card, the test for blood, and the short colonoscopy, the sigmoidoscopy. There's also a virtual colonoscopy.
that's what I was going to ask about, advancing technologies.
So virtual colonoscopy, that's not a win. That also has a role. So what's a virtual colonoscopy? Essentially, you still have to do a prep the night before, so you don't get out of that. Right? But now you go to a radiology suite. You don't go to an endoscopy suite where when we do a colonoscopy, you get sedated. I said you're very comfortable during that procedure. Virtual colonoscopy, you get no sedation. You go to the radiology suite and they essentially give you an enema, which is where they inject fluid into your anus to fill your colon, and you're up for the entire procedure. If that wasn't bad enough, if they identify something, they can't do anything about it. That just tells them that you need to go get a colonoscopy. So now you have to do the prep again so we can do it. So another reason to get a colonoscopy is not only do we identify things, we can sometimes resolve issues as well.
Absolutely.
So again, who do we recommend a virtual colonoscopy for? Well, one type of patient would be someone who we can't do a colonoscopy or perform because they have something blocking them. So we still need to assess their entire colon, but we can't do it because they have a narrowing. That's where a virtual colonoscopy may come into play. Another group may be some patients have very long colons. I mentioned that colons can be about 5 to 6 feet in length. Well, some are longer than that, and you can't reach the beginning.
Mm-hmm.
And so you have to do a virtual colonoscopy so you can assess the entire colon. That's the thing with a colonoscopy. The entire colon has to be looked at. You can't look at half of it, can't look at 90% of it.
Mm-hmm.
It's all or nothing. Like
Yeah.
You can't be a little bit pregnant. You either are pregnant or you're not.
Yeah,
Either you got
that's
the
true.
colonoscopy or you didn't, period.
Mhm.
And so that's the other group that might get a virtual colonoscopy.
Okay.
So
That's good to know. I know now I have my choice. I would definitely get a full colonoscopy to start.
I would recommend it. Highly.
Comfort is key.
So I have a family history of colon cancer. So I started getting my colonoscopies at 45, but then the interval time between my next one was shortened to 5 years. So
Correct.
now I get them every 5 years, which is,
Mhm.
I'm like, why can't I be on the 10-year plan? Like,
Statistically, you can't be on the 10-year plan because your risk of developing colon cancer is higher. And so, we look at all of these markers, and we think that if you have a colon that has no polyps in it, it would take about 10 years to go from having nothing to developing a polyp, and that's gone through its own evolution. When I started, everyone was getting colonoscopies every 3 years.
oh, wow.
That was the recommendation. It didn't matter if you had a polyp or not, every 3 years. Then it got bumped to every 5 years. Then it got bumped to 10 years. For patients with family histories, they didn't get the bump from 3 to 10. They got the bump from 3 to 5, right? And that's because we think that because you are at a higher risk, your rate of polyp growth is higher. So therefore, we need to review your colon at a shorter interval to make sure we keep you safe. I do get the question, well, now, doc, this is my 6th
Right. When does it stop?
colonoscopy in a row.
Exactly.
It's all been negative.
Yeah.
Can I stop?
Yeah.
I don't have an answer for that. I have a patient that did that, and she turned out to have colon cancer when she went back to get her colonoscopy. So I would say no, just from my own personal experience. But again, the data's not out there to say that after X number of colonoscopies, if you're okay, then you should go back to the regular risk pool.
So it's really important to stay diligent and follow up with your doctor as scheduled and not fall off that schedule.
Correct.
So in addition, what are some things that we can do to prevent colon cancer? Like, are there diets that we need to avoid? I've heard a lot of having processed foods and processed meats increase the risk.
So this is the problem with the American diet, right? So there's just a recent, which everyone's talking about, nitrates, which is in hot dogs and all your processed meats, your food from the butcher, those cold cuts that you get. All of these things have nitrates in them. And so it's tough, knowing that these things can lead to cancer. I've been doing my best to avoid them, but I love hot dogs. I love cold cuts from the butcher. But these types of processed foods that we eat in this country have a high incidence of colon cancers in patients that eat large quantities of them. We don't know the quantity. Is it 1 hot dog? Is it 50 hot dogs? Is it after a year? Is it after 5 years? Bottom line is nitrates can cause cancer, so you should try to avoid them. And you should be looking at the packages to see what nitrates, where they are. I was eating protein salami sticks. I thought, well, this is healthy. It's got 30 grams of protein in it. This is great. And I decided to look at the ingredients, and smack dab, there's nitrites. I'm like, there's another thing I can't eat, So it's not the end of the world, but nitrites are a big thing. A low fiber diet. So here's where it gets kind of confusing. We're not sure if a low fiber diet leads you to a higher rate of colon cancer, or the fact that people who generally eat lower fiber foods generally eat more meat. So is it the fact that increases in the consumption of meat cause a higher incidence of colon cancer, or is it the fact that you're eating less fiber? It's probably some combination of both.
Mhm.
So incorporating more fiber foods into your diet can be very protective
Mhm.
against colon cancer. Can also be protective against another ailment called diverticulosis, but we won't go into that topic. It's for another day. But high fiber foods, fresh fruits, fresh vegetables, wheat breads, bran cereals, water. We have,
Yeah.
I can't tell you how many times I tell patients that they need to drink half their body weight more.
Mm.
They look at me like I'm nuts. This just happened again today. Yet this gentleman was drinking a ton of coffee, juice, soda. It ended up to much more than half of his weight in fluid. But it's just that when you say water, it just turns everyone off. It's just like you go to a restaurant, water is at the table. The first thing the waiter asks you is, what would people like to drink? Well, there's water sitting there. Clearly no one wants to drink that, so bring me these things. So keeping your water intake elevated is very important. And exercise. We don't talk enough about that. People who smoke, smoking has a bunch of bad things that it causes. Colon cancer is another one to add to the list of those bad things too. So if you smoke, you should try your best to quit smoking. Because that can help prevent colon cancer too. So all of these factors that are doable, it's just that we don't do them, can help decrease the rates of colon cancer and polyp production.
Yeah. So let's say you are unfortunately someone who's diagnosed with colon cancer. How is it treated, and how do we start talking about it? I know from my perspective, the first thing that my patients will say to me is, okay, I have cancer. So they're very, very scared. And then they say, okay, what's the stage? So can you talk a little bit about what stage means in colon cancer and why it's important for them to understand?
So for colon cancer, and I think for most cancers, there's 4 stages. And stage 1, 2, 3, and 4. 1 being the lowest stage, or the one that has the best prognosis. 4 being the worst stage, or having the worst prognosis. So with colon cancer, it's an interesting thing, because when people come to the office to discuss possible surgery, you'd think that they would be more focused on the cancer, but they're actually more focused on, do they need a bag to poop in?
Yep.
Yeah.
So
Yeah.
I can have
Yeah.
a very lengthy conversation
Yeah.
about surgery and chemotherapy and all these things. And then we get to the bag, and is it needed? And that's when they start to lose their cool a little bit, which is always interesting to me, because cancer, you would think, would be in the front seat of this conversation. But for colon, it's a little different dynamic that happens there. But essentially, depending on your stage with colon cancer, surgery would be the first option. If you're in stage 1, 2, or 3, surgery will be your first option. If you're stage 4, which means it has metastasized to other areas of the body, then you're going to get treated with chemotherapy first. And that's a change from when I was a resident. You always went after the mother tumor first, and then you treat it with chemotherapy later. But studies have shown that the results are worse when you do that. So you want to treat the patient as quickly as you can for those who have metastatic disease with chemotherapy, with the hopes that you can get it in control, hopefully even cure it, and then set them up for surgical intervention. Just because someone needs surgery on their colon does not mean they automatically need a stoma or a bag to poop into. More often than not, you don't need that. Your surgeon will never be able to guarantee you that you don't need it, because things happen in the operating room. Sometimes you find disease when you didn't know that you're going to find it. Sometimes the patient's not very healthy. Location of the cancer in the colon makes a difference. But for the most part, patients who require surgery don't require stomas. You sit down, you talk with your doc. Don't let fear keep you from having the conversation, because you might be surprised about the results.
Yeah. Are there minimally invasive ways to treat colon cancer?
So, boy, that's so many different ways. So when I started, you only did surgery through a large incision. That was it. That was all we had to offer. Then things started to evolve, and laparoscopic surgery started to catch on, and we started to do more small incision type surgery, and now we're doing a lot of robotic surgery, which is really the thing now.
Yeah,
that's the new thing on the scene. And I can tell you that within my practice, I converted almost completely over to robotic surgery. Not everyone can be done through small incisions. There are anatomical variations. There could be the tumor that's too large to be manipulated robotically, but the vast majority of patients can be done robotically. And how their recuperation from that surgery, their length of stay in the hospital, is just night and day. Everyone has pain, so I'm not selling it that those patients who have robotic surgery have no pain, but their pain doesn't last as long. They're not in the hospital as long. Their recuperation is quicker. Their return to bowel functions faster, which means they get to start eating a little bit quicker. Just the whole thing is better through the minimally invasive is the way that we'd say that, minimally invasive approach. Sometimes you can remove the tumor right through the anus and it doesn't require an incision at all. And those patients sometimes don't even spend a day in the hospital. They go home the same day. So a lot depends on anatomy, prognosis, age of the patient, health of the patient, but minimally invasive is really what people are doing now mainly.
Wow.
Yeah.
I think that is very important, because we do know that a lot of patients are discouraged when they think about having a bag, feeling, the social isolation that might accompany that. So I think it's good to hear that modern technology and surgeons like yourself are doing the best for these patients and helping them get through cancer in a way that I think preserves part of their dignity also.
Yes.
So I think that's a good point. So you've answered a lot of questions about colon cancer today, and just in general. So let's say you have a patient that has colon cancer, has gone through the treatment, gone through the surgery. What are their next steps? What should they expect?
So after surgery, and again, depending on location, how you handle surgery and some of the recuperations can be different, but just overall, once you're cured of colon cancer, and colon cancer, if you catch it early enough, does have a very high success rate too, which again brings us back to the colonoscopy and why it's important to get those even when you feel good. The problem is when you start having symptoms, that oftentimes means that the tumor has progressed to a level that may be beyond the point of cure. So you don't want to wait for that. Now, if you are experiencing those symptoms, don't use that last sentence I said as a reason not to go get checked, because that's not the case for everyone. So you just want to be on top of things. But after you've gotten treated surgically, and for those who may require chemotherapy after surgery, because staging does play a role in who gets chemotherapy even after surgical intervention, then you have follow-ups. It's usually a 5-year follow-up that you will have with your oncologist. That doesn't involve surgery anymore, but involves CAT scans and blood work and physical examinations and colonoscopies. I said that enough.
Oh, man.
So for those who get diagnosed with colon cancer, they would get their first colonoscopy 1 year later. And I always tell them, you're not on a yearly colonoscopy schedule, because that's their look tells me that they're thinking this is going to happen every year. So I tell them, no, it's not going to happen every year. But you have to get one at that very first year to make sure everything is healed from what we did, make sure there's no new polyps, nothing that we missed. Then if everything looks good, then you're on a 3-year schedule. Amy, you mentioned you're on every 5 years. So that's because you have a family member. But that family member with colon cancer is on a 3-year regimen. And that will never change. Same rule applies to them. What happens if it's their 7th colonoscopy and it's been negative? Is it okay to stop now? Nope. We don't have the data to support that. So you just keep going for your routine visits. From your oncologist standpoint, once you reach the 5-year mark, they're kind of done with you at that point in time. They're like, well, you've done well. Everything is clear. You don't keep getting CAT scans. You don't keep getting all this blood work. Once you reach that 5-year mark, you keep your colonoscopies going, but you do not need to. Your oncologist now backs out, and now you're just under the care of your primary care doctor.
Okay. I think that was a great discussion today. And just my take-home point is the importance of prevention.
Yes.
So making sure you stay in tune with your body, making sure you're hitting those milestones for your colonoscopy. I think that's a super important aspect of really catching this disease, and prevention is key in trying to catch it as early as possible. But do you have any lasting words for our audience so that they can take home?
Mm-hmm. Get your colonoscopy.
Yes.
Don't be afraid. There's no pain afterwards. You'll be fine. I hear that a lot. Will my butt hurt after the colonoscopy? Your butt is not going to hurt at all. And for the most part, you're very comfortable throughout the entire procedure.
All right. Well, Dr. Timothy Adams, thank you so much for joining us with Healing with Her today. And this was a wonderful conversation. Do you have anything to add?
One last thing. People who have no insurance can get a colonoscopy by going through the Erie County Department of Health.
Correct. That's
Awesome.
absolutely true. So
Mhm.
there's
Thank you.
no excuse.
No excuse.
No
not to
excuse
get
then.
it.
Hey.
Thank you, ladies, for
Thank
having me as
you.
well.
Absolutely.
so
Thank
much.
you so much with Healing with Her. We'll
And-
see you next time.